Hi, my name is Zach Schrader. Going to be presenting today the debate topic for SPCE 619, ethics. My partner is Brianna. She'll introduce herself right now.
Hi, my name is Brianna Scott. I'm also going to be presenting alongside with Zach for our ethics presentation debate.
So our topic was the use of restraint and seclusion with individuals with autism spectrum disorders. And initially, before we can really talk about the ethical ramifications of the use of restraint and seclusion, we kind of wanted to go over some of the regulations that surround the use of it, both in residential settings and in schools. So Brianna is going to speak to that a little bit.
Okay, well, pretty much prevention is the ideal approach. When we look at the least restrictive measures according to the ACB ethics code, code 4.09, it states that the behavioral analysis reviews and appraises restrictiveness of procedures and always recommends the least restrictive procedure likely to be most effective, which brings me to the fact that the prevention is always the ideal approach. This pretty much specifies that we should exhaust all measures that we can where we won't have to utilize seclusion or restraint. That should be the last thing that we gravitate to when we have our clients in these situations. And so that's pretty much what the ethics code 4.09 specifies. Before implementing any punishment-based procedures, it is stated that the behavior analyst should ensure that the appropriate steps have been taken to implement the reinforcement-based procedures unless the severity or the dangerousness of the behavior necessitates or immediate use of aversive procedures. So there is no reason to tackle on seclusion and restraint instantaneously without wearing out other options.
All right. Looking at some of the guidelines and regulations that surround the use of restraint, all of them really lie in the exact same ideology of only use as the last resort. So in 2010, the U.S. Department of Education released a comprehensive report of all the U.S. states and U.S. territories and their statutes, regulations, policies, and guidelines surrounding the use of restraint and seclusion in those states and territories. And it was found at that time when they went through that 16 states had thorough direction in terms of the usage of restraint or seclusion, in that they had regulations, statutes, policies, and guidance that directed how they would utilize those. There were 15 states that had some level of guidance. They either had regulations or statutes in place, or they had some policies and guidance at the state level. And then there were, I apologize, there were 28 states with thorough direction, 16 states that had some direction, and then there were 15 that had no formal guidance whatsoever. They had no policies, no procedures. All 8 of the U.S. territories, places like Guam, were within those areas that had no formal direction. And I will bring up a map that gives you a little bit of a view of kind of the distribution of that. So green is just thorough guidance where they have coverage on pretty much every level. And then yellow, some guidance. Red has no formal guidance. So looking from that, in 2012, the federal government, the Department of Education, released a resource document that gave direction to states and districts about restraint and seclusion. It was occurred in part due to the 2010 audit of what the regulations currently were, and also to the 2009 U.S. Government Accountability Office report regarding restraint and seclusion, specifically restraint and seclusion that resulted in death, that identified that there's no current federal regulations at that time that exists about the implementation of restraint and seclusion, not just with individuals with autism spectrum disorder, but with any individual. And it was found that that's primarily related to lack of training or poorly trained staff that led to the issues with restraint or seclusion related death. So that report identified 15 core principles on the use of restraint and seclusion, and the first principle of which is that every effort should be made to prevent restraint and seclusion. We should be utilizing all possible techniques prior to getting to that point. Like Brianna said, we should be using the least restrictive measures, and that should only be utilized as an absolute last resort. That leads into the first real large ethical concern related to restraint and seclusion, which is the risk of injury or death when implementing physical restraints and utilizing seclusion. So Brianna is going to talk a little bit about that.
Okay. Yes, the risk of injury, death when implementing physical restraints and seclusions. There have been a lot of incidents that have occurred around the world in different states where children, students, and clients alike have been placed in experiences where they were restrained or secluded and resulted in death or injury. There was one particular child that had a disability history of bolting out of rooms when her anxiety increased, and this happened in New Hampshire, where her classroom teacher came up with a plan that she did not clear with the school board of pretty much locking her in a scream room. And in that instance, she ended up banging her head against the wall because she wasn't being supervised, and she left out with a lot of bruises and abrasions to the body. That's just one of many instances that have occurred where students have been placed in either secluded location or restrained in a way where they weren't being supervised, and it resulted in injury to the body. There was also an instance in New Mexico where a student, a 6-year-old child with Down syndrome, was restrained on a school bus by a school driver attendant, and they were standing outside, and they were not paying attention to this child, and the child threw a shoe out of the window. And while that occurred, the aide saw the child strapped to the seat with a seatbelt around his neck. He was trying to get out, and he was not able to have that assistance because no one was paying attention to him. And he almost ended up being strangled to death while sitting on that bus, being restrained by that seatbelt. And there are countless other examples of this happening around the world in different states where people who are not trained are doing their own thing in terms of restraining these children or putting them in seclusion because they don't want to, I guess, deal with them, or they don't know how to handle the situation in the best way possible. As it was stated in the Ethics Code 4.09, these are the last resorts. All other options should be exhausted first before getting into situations such as these, because they can be very detrimental to the individual client or child in the end if not handled correctly, and not handled correctly by the right personnel. And so those are a few of my examples of the risk of injury when implementing these physical restraints and seclusions.
So tying in with those examples that really show the kind of applied nature of the risk of injury, also that the U.S. government accountability findings that showed restraint-related death and seclusion-related death primarily are stemming from issues of lack of training or poor training oversight. So there are a wide number of evidence-based crisis intervention programs that utilize restraints. So when attempting to rectify this ethical concern of the risk of injury, the best solution often is providing adequate training to staff that may have to implement. So some examples of these evidence-based programs are therapeutic crisis intervention, TCI, which was developed by Cornell University. It was based on a study of child abuse in 1979 that occurred in New York group home institutions. TCI did a follow-up study with the same institutions that found a significant decrease in reports of abuse or neglect after implementing therapeutic crisis intervention. It is still used widely today in school and residential settings. Another evidence-based crisis intervention model is strategies for crisis intervention and prevention. It's shortened to SCIP. It was developed by the Office for People with Developmental Disabilities, OPWDD. It's a New York State office. It was developed in 1988, revised in 1998. It's utilized across residential settings in New York State, and it's constantly reviewed to make sure it's providing the best training to staff who are going to be implementing these emergency physical restraints. Safety care, which is developed by Quality Behavior Solutions, QBS. It was created in 1997. It's focused on function-based prevention and intervention. All QBS certified instructors are board-certified behavior analysts. So it provides training that is rooted in functional thinking and behavior analysis in order to provide staff a level of training that will allow them to implement physical interventions only as a last resort, and also provide staff with those proactive and preventative measures. The MANT system was developed in 1975. It's based out of Texas. Its goal was to design a training program for staff in residential facilities that serve individuals with developmental disabilities. So from its inception, that was its focus. And then there's also professional crisis management, which is PCM, developed in 1981 by board-certified behavioral analyst Neil Fleising. It focuses on ethical treatment of individuals, again, preaching that intervention should only be used, those physical interventions should only be used as a last resort, as is with seclusion. It looks at the individual in the restraint as an active participant in the intervention. So the physical restraints aren't something that is being done to a student, which kind of separates staff from them. That focuses us on the safety of the student or the client who is being physically restrained. And nonviolent crisis intervention, which was developed by the Crisis Prevention Institute, CPI, was developed in the 1970s. Its course philosophy is care, welfare, safety, and security for everyone involved, including the individual in crisis. So when we're looking at things like restraint and seclusion, do we use them? Are they appropriate? Are we at that last resort stage? Really focused on that risk assessment based out of Wisconsin. So those were just 6 examples. There are a plethora of training options available for staff to limit that risk of injury or death occurring in restraint by giving proper and adequate training, and more importantly, evidence-based training that is behaviorally focused and is allowing staff to learn not just the proper way to implement physical restraint or implement a seclusion-based technique, but to learn the proactives and preventatives to be utilized beforehand. A key part is weighing the risk of the physical restraint, weighing the risk of the seclusion versus the risk of the behavior that's being exhibited. As we have both kind of stressed multiple times, it's only a last resort method. It is only to be used when all their options have been exhausted. So these aren't interventions that are occurring without thought, and they're not interventions that are occurring for low risk behaviors, which is very important when determining how, in those training programs, give staff the tools to identify and assess risk and determine when the use of these restrictive procedures is necessary and when it is not. Um, an additional ethical concern beyond the physical risk of injury or death goes to the risk of trauma to the individual, damaging the relationship between practitioner and client or staff and student, whatever it may be. So looking at that as kind of a second ethical concern inherent to the use of restraint and seclusion. I'll let Brianna expand on that a little bit more.
Yeah. So the risk of the damage to the relationship moving forward, inciting past trauma or creating new trauma. The best way that I think we can all understand a situation such as this is based off of examples. There was a situation that occurred in Florida where they restrained an already traumatized student. It was a case where a 6-year-old boy who had autism spectrum disorder and epilepsy and Tourette syndrome and respiratory problems. He was traumatized while he was at his charter school as a result of the misuse of restraints and seclusion at the school. He was attending a different school, and despite the post-traumatic stress disorder diagnosis, the school's plans for him included the use of restraints and seclusions. Now, his parents were concerned about his tantrums and the anxiety that he was experiencing increasing, but the school decided to continue with that plan. Because of that, it resulted in him every time he was at the school engaging with different teachers or different staff, his behaviors increased in kicking, hiding. Every time he was around certain staff, he would engage in tantrums and continue to kick and hide from those individuals because of the trauma that he was experiencing with the misuse of restraint and seclusion. We fail to realize how our actions in essence, plays a big role on the mental state of the individual, whether it is a child or an adult. It can be very scarring to that individual, and it leaves lasting effects where resulting in trauma. And that is what happened with this 6-year-old boy. Moving forward, it shows that it stated that he has never been the same. He has a big issue with cooperating and working with any therapist or psychologist because he's in fear that he's going to be either locked in a room or restrained in a certain type of way. And so he's always, when he is engaging with a new therapist, he's either kicking or screaming, and it makes it hard now for him to move forward in life, in his daily life. In a normal school, he has to be homeschooled because of the lasting effects of the misuse of restraint and seclusion. It is very imperative that we take into account our client's history. This 6-year-old boy had a history of autism spectrum disorder, epilepsy, Tourette syndrome, and respiratory problems, and still, without taking that into account, the school decided to still implement the misuse of restraint and seclusion when he had all of this going on for him in his past and in his present. And that, of course, because they disregarded that, made a lasting traumatic effect in his life. And that can happen to anyone, because just as a behavior analysis must review an intervention to see if it's plausible for the client. The same process should be utilized surrounding any physical restraints, trauma, or any client history needs to inform. This is definitely an ethical concern that any professional should be aware of when implementing restraints and seclusion, the lasting impact it has on that person's life and quality of life moving forward.
So there was a really interesting study done in Australia, actually. It was survey based of individuals who had been in inpatient and outpatient receiving psychiatric care. And the results really show the viewpoint that's taken by individuals who experience this restraint and seclusion. So I'm going to give a couple of visuals. So looking right here, out of the survey, over 1,000 individuals responded. 54% had experienced restraint and or seclusion in their inpatient stay, with 46% having not experienced it. And then as they dive deeper into this, we're looking at, out of the little over 1,000 respondents, 322 individuals were both restrained and secluded in their inpatient psychiatric treatment. 102 were only restrained, 136 only experienced seclusion. And then opening up and looking at the patient attitudes, which isn't unexpected, but it is a jarring number. 94% of the individuals who had been restrained or secluded had commented negatively regarding the use of the restraint or the uses of the seclusion, with only 6% commenting positively in terms of viewing it as a necessary intervention or believing it was done properly. So looking at that, the primary complaint presented, the primary argument presented by those individuals was that it was done prematurely. It was unnecessary. Their behavior did not elicit the use of restraint or seclusion, or it was done in a punitive manner, which we've talked about previously, how that is not the intent or the proper usage of physical restraint or seclusion. So as you unpack that, kind of the trauma that can elicit itself through these interventions is very clear if it is that overwhelmingly negative of a response. So taking into account the individual's history, that gave Brianna's example gave us a very vivid example on an individual level, and the study gives us kind of that big picture numbers view of misuse of interventions that are as restrictive as restraint or seclusion can lead to highly traumatic experiences for the individual, and aren't necessarily going to be effective in eliciting positive behavioral change. A third and final kind of ethical concern among the many when looking at the use of restraint and seclusion is you do run the risk of inadvertently reinforcing negative escape motivated behaviors when you use seclusion. So if negative behaviors are occurring in order to escape demand tasks, escape things that are being asked of an individual, the use of seclusion could reinforce that. Brianna is going to talk to that a bit.
Yes. So pretty much with secluding clients from their settings, it can, as Zach said, reinforce escape-motivated behaviors, thus compounding maladaptive concerns. Some behaviors that can be showcased, like the previous example I gave about the young man kicking, the 6-year-old kicking and hiding, that was increased. Physical aggression is one example that can be increased. It's running away and can't really come, it's not coming to my mind, but yeah, there behaviors such as those can be increased when when an individual is experiencing that is about to experience the seclusion and restraint. Yes.
Yeah. So here's kind of a competing behavior pathway that looks at the process to get to that. So if you have an individual working with a less preferred staff, they might be ill, they didn't sleep the previous night as a setting event, and then you present a demand task to that individual, and then the problem behavior occurs, which is aggressive behavior. If our staff response is to remove the demand by placing that individual in seclusion because they aren't going to be able to access that demand as we take them to a seclusion room or whatever may be utilized, that aggressive behavior is more likely to occur in the future. We just reinforced it. If you want to escape, engage in aggressive behavior and you will be brought to a seclusion, which allows you that escape. So we should be teaching those alternative behaviors, appropriately asking to escape the demand with phrases like, I don't want to do that, no thank you, which also allows the demand to be removed, while ultimately developing those coping skills that will allow the individual to tolerate the demand activity when it is scheduled, so we can get that desired behavior and consequence of engaging with a scheduled demand and moving forward with what's going on with their day. These restrictive practices, if they're used in a manner for ease, which is not the intended purpose of them, because it's easier than properly behaviorally programming these intense behaviors such as aggression, such as self-injurious behaviors. So we're just going to use a seclusion room or use a timeout. We're running a huge risk of reinforcing that behavior, making it more likely to occur in the future, and making the individual, the client's time much more difficult. It is creating a strong history of reinforcement that will then have to be unlearned. So it's something to be very aware of as we utilize these strategies.
May I interject?
Absolutely.
Yes. I like what you just said, and it brings me to another example of an incident that occurred January 2011, where a child was placed in a seclusion room and was not allowed to leave the seclusion room to use the restroom. And because of this, he ended up always peeing on himself in the seclusion room because they wouldn't allow him to use the restroom. Every time a situation would occur and he was secluded again, he would pee on the floor in the seclusion room. On this specific day, the final incident did occur, and this time, instead of peeing on the floor, the young man ended up trying to hang himself in the seclusion room. Luckily, they were able to get there in time, and he did not end up killing himself. But it goes to show you that when you are placing these individuals in these predicaments, whether it's seclusion or restraint, it forces them to act out in a way where you are reinforcing some really adversive behaviors, and it can also end up with it being a fatal experience as well. And so we need to be aware of these risks and do our best to incorporate other alternatives so that we can keep the individual safe and be in that experience.
Yeah. So, kind of wrapping up, looking at our own personal experience regarding restraint and seclusion. I currently work at a self-contained school that serves individuals with developmental disabilities from ages 3 to 21. The vast majority of our students have autism spectrum disorder. and I serve in the role as our crisis intervention supervisor. So I oversee the implementation of our evidence-based crisis intervention plan. I am a certified trainer in nonviolent crisis intervention presented by Crisis Prevention Institute. I'm a certified trainer in therapeutic crisis intervention by TCI, which was developed by Cornell, and I was previously certified in safety care, which was presented by Quality Behavior Solutions, QBS. So I have a bit of experience in the oversight of physical restraints and also the implementation of physical restraints. So I stress daily the need for these to only be used as a last resort, really weighing the risk of the physical intervention versus the risk of the behavior that's occurring. I do not have extensive experience with the use of seclusion. We don't use timeout rooms or things like that at the school that I am at. So that's something that I'm not as well versed in. And Brianna can fill you in on her experience with the subject as well.
Well, I don't have as much experience as Zach does where that is concerned. I'm CPI trained, but pretty much I currently don't work there anymore, but I worked with a behavioral health as their assistant to their behavior specialist. And we never used restraints. We never had to use restraints, and we didn't use any kind of seclusion tactics. I worked primarily in a group home, and it was pretty much calm. So I've never really experienced hands-on where I had to de-escalate a situation actually utilizing CPI. But just based off of my experience with the research that we've been doing and looking up all of these situations and circumstances of different students and clients who have experienced seclusion and restraint, I agree completely with the ethics code 4.09 that the last resort should be seclusion and restraint, that we should exhaust all measures possible to make sure that we don't put our clients and individuals in jeopardy and even ourselves. And so that's my experience where that is concerned.
So there are a few kind of wrap-up questions that are common to the topic. So any strategies or methods that can be used to improve training for administering restraints or decreasing the need for restraints. Strict oversight of training. The first step is having that evidence-based program that is trained to your staff. Oversight of it, making sure there are frequent opportunities for things like refreshers, things like in-services to develop those skills, because we know that with skill drift, it's possible for those to atrophy. And the last thing you want is a poorly trained staff implementing a restrictive intervention such as restraint or seclusion. So making sure that there's strict oversight and strong oversight of those training programs, and also solid behavioral training in behavioral skills when you're working with populations such as those with autism spectrum disorder, individuals with developmental disabilities. If you give that function-based training, staff can be consistently working towards promoting those positive behaviors to hopefully decrease the need to ever get to that last resort moment. So kind of increasing the knowledge base of all staff who are utilizing these is a good way to decrease the need, as well as kind of improving the fidelity of the implementation and administration of them. Another one that is frequent around the topic is, if restraints or seclusion are deemed necessary, how would you go about determining the appropriate crisis intervention program? I listed 6 earlier. There are at least a dozen more that are evidence-based. So it's looking at what is feasible for your agency, what's feasible for your population. Some of the intervention programs have been developed or utilized with differing populations. So it's finding what is most functional for your population, for your agency, and also looking at things like state guidelines and state regulations. Some of the physical restraints that are taught in some of these courses are supine restraints, which are on the floor with the students back on the ground facing up, or prone restraints, which are on the floor, student facing down with their back facing up. And in some states, those are not allowed. Some states have regulations that specifically prohibit the use of supine restraints or specifically prohibit the use of prone restraints. So if you're utilizing a restraint philosophy that incorporates one of those, it's not going to be a viable option. So you need to look at things like that when determining what the most appropriate program is going to be, the most appropriate implementation. And kind of segueing off that in terms of looking at regulations, an example that was provided to us about how the usage varies from setting to setting, about if it's ethical to use them as a way to address behavior if it can't be used globally in any setting. For example, apparently in Indiana, mechanical restraints are not recommended to be used for people in adult services. So the ethical concern of how do you kind of rectify that situation if you feel a mechanical restraint is the most effective method of addressing a behavior when it reaches an unsafe level, if you have an adult client who may go to Indiana and need to receive services there. So to resolve that, I think you need to look at, one, what is in the best interest of the individual, and two, what is going to be a viable and feasible method, because if it's not going to be able to be carried out with fidelity, it isn't going to be a viable option, as opposed to something that will still keep the individual safe and is able to be used globally. So you need to view regulations, guidelines, statutes, limitations, not only where you are, but in any setting that it's feasible that a client may be. So making sure that you have everything covered. Because if you aren't living up to expectations, you're not going to be able to serve that client or any other client. So you need to be able to meet the expectations of the regulations and the guidelines in order to provide services to your client. So making sure that those are all addressed kind of across settings. Brianna, do you have anything to add?
Yes. Also, I know you touched on training. It's a big part of dealing with circumstances like this. There are many individuals, teachers, staff, behavioral techs who are unaware of how to handle situations such as these or de-escalate them appropriately. And I believe that the method of allowing every school with it doesn't have to be a person specifically on a spectrum. It could just be a regular child who just goes to school on a day-to-day basis. I think all teachers should learn the best ways to de-escalate a situation without utilizing those kind of avenues with restraint and seclusion. I think it's something that the general public should all have some form of training and understanding in. Police officers as well should be able to know the best ways to deal with individuals with disabilities and on the spectrum or with mental disabilities as well, and in the safest way possible, because there are so many incidents out there where you hear about a police officer manhandling autistic teenager or an autistic adult, and resulting in the person being bruised or even dying. I have a situation where my cousin, may his soul rest in peace, he was bipolar, and he was off his medication, and he went to a convenience store, and he reached in his pocket, and the attendant there thought that he had a gun, which he didn't. It was just his wallet, but it became this big issue. And because he wasn't on his medication, he started acting out. And instead of taking the necessary precaution precautionary methods needed to de-escalate the problem the right way, he ended up being shot down and died there in front of his friends and family, because they didn't, first of all, understand that mentally he wasn't completely stable. They didn't try to see, what could be a possible trigger and why this was happening. They just looked at him as, being a criminal because of the way how he carried himself, but they didn't realize he just was off his medication, and it resulted in something fatal. And so I just say that to go right back to the ethics code. We need to make sure that everyone is aware. I feel like it's vital that all people should be aware of the best way and the safest way to deal with anyone with a mental disability or on the spectrum, deal with them accordingly. There's always a better way. Violence and restraints and seclusions, all of that is not always necessary. There are different steps that you can take before you need to get to that route, and we should heavily consider those steps first before we get to restraint and seclusion.
Absolutely. I think that sums it up about the best. So thank you. This has been our debate topic. Thank you very much.